We're now live, Chair.
Thank you very much, Kirsty, for your help and support in the background. So it is 6 o'clock, members, so welcome to the Adults Health and Social Care Scrutiny Board on Thursday, the 6th of October, 2022. I really don't know where the year is going, but I do know that the nights are getting colder and it's getting darker and it's a miserable time of the year. Oh, it's a cozy time of the year, whichever. Anyway, welcome everyone. So, substitutes nominated for this meeting and apologies for absence. I've had no substitutes, as I'm aware. No, Kirsty, thank you. Apologies from Councillor Ford. So I'm just looking at some notes as well. So apologies from Councillor Ford, no one else. So let's go on to item number 2. Members' interest for members to declare the interest at the relevant times. Item number 3, admissions to the public. It's not recommended that the public be excluded from the meeting for considerations of items of the business on the agenda. And if anyone out there is watching us on YouTube, you are most welcome. So item number 4 is minutes of the Adults Health and Social Care Scrutiny meeting held on the 1st of September 2022. I move those as a correct record. Colin, can you second those? Thank you, Colin. Right, okay, and all in favour, please, just show your hands. Thank you. Excellent. Okay, so item number 5 is the Adult Services and Wellbeing Complaints and Compliments. So the Interim Director, welcome. Welcome, Kath. Sorry, my apologies.
Oh.
Welcome to the meeting. I saw your name. I didn't recognise you. That's why I didn't recognise you, because you're very new to the post. So welcome to Calderdale. A very big welcome to Calderdale. It's really nice to have you on board on this meeting, and we really do look forward to working with you over the hopefully over the many years, because you won't want to leave Calderdale once you start working here. So hopefully, very much welcome, Kathy. It's really nice to see you in Zoom, and as I say, we'll work together, I'm sure.
Oh, thank you, Councillor Bradbury. I'm absolutely delighted to be here, I have to say. It's day 4, so it's very early days, but I've had a very warm welcome, and it's great to be here. Just to say, I think Lynn Hagan was going to come to present the report on. And
Lynn's here, or she was here. I've seen her somewhere.
Right.
Oh, have I lost her? I'm just looking for.
I'm here.
Oh yes, Lynn. Sorry, you were hidden over there was a message over your face. So it becomes extremely complicated when there's a message over somebody's name and face. So welcome, Lynn, and thank you for coming to Scrutiny and presenting your report. We've had a copy of your report. Is there anything else you wish to add to the report that members need to be made aware of?
There's just one small note on the background note. It relates to the Care Act 1990. It should be 2014. I just wanted to correct that. Apologies.
No problems. So anything else to add to the report, or I think it's fairly self-explanatory?
Yeah, if there's any questions that anyone wants to ask or any feedback or specifics.
Indeed. Good. I'm just looking around the room. Specifically looking to Councillor Hutchinson. Yes, he's not failed me. Councillor Hutchinson, your first question.
Thanks. The examples of learning from complaints that are quoted are all about the administration of the provision of care or commissioning of care. The vast majority of it is obviously delivered through independent companies, or I'm assuming that complaints about the standard of care that's actually delivered rather than that's commissioned is also fed into this process. But I can't see any, there's 3 examples of the learning that's come from this, but none of them are related to the actual delivery of care, as far as I can see.
Lynn, do you want to come back on that? Yeah.
Yeah. What I would say to you is, as each complaint comes through, and some of them can be quite lengthy, there is a learning log that's presented back to each team and service area, and there's been a considerable amount of work done, certainly over the last 2 years, to make improvements, and those improvements have been seen in the numbers that have gone down. And the approach, there is a nominated officer who makes sure that the learnings that we get and the learning logs are followed through, and that goes to care providers as well. And it's obviously encapsulated into any future renewals of contracts for service and staff conduct, and it covers that whole arena, and it's reviewed in monthly team meetings. So it's not something that's just issued at once after a complaint. It's very important for us to take those learnings and to make the service improvements. I think the examples given obviously focus on the admin area, because we get quite a lot of comment on payments and things like that. So it's a higher number of stats that are represented there. But what I'd like to assure you is that there's the full follow-up either with service providers or even our own internal staff and partners on that side of it, to make sure that those measures are put into place and revisited.
And do any of the complaints or compliments come directed through Health Watch, and how are they fitted into how are they incorporated in the reviews?
Predominantly the complaints come in through the complaints team, which is our corporate process. And obviously, depending what that complaint is, it's then allocated to the appropriate stage and the legally binding process that we've got within adult health and social care, and the same for children's services. The Health Watch complaints would be dealt with by them directly. Some issues will be dealt with as a service matter, because something that presents as a complaint initially can sometimes simply be a service matter where there's a communication path that's needed. And it has to be judged on each individual case, because we're all unique in that approach. So it's difficult to split out. Something may instigate from Health Watch, or they may feel that they've not had the right response, and then they will come to us directly. And then we find the appropriate channels to address it.
No, it's just that, they're all opportunities to learn where the cracks are, where the gaps are in services, and where things could be improved. So it's just important that it is all brought together at some point.
No, most definitely, and I think the most important thing is complaints are often seen as something negative, but it's you get much more positivity out of that, because if you're not a service user, you may well think that you're doing something well until somebody tells you differently. And you get that chance to, repair that and revisit that.
Thanks.
Thank you, Lynn, and thank you, Councillor Hutchinson. So not only do you take one to the person asking the first question, but you also finished my question as well about Health Watch. She was very much a key, but that's splendid. Councillor Kingston, please. You're just on mute at the moment, I'm afraid. What famous last words?
Classic, isn't it? Classic. I noticed on the bar chart of the type of complaints that there seemed to be there is a significant increase in complaints about finance, in that category of finance, and I just wondered, is there an explanation for that? Previously, there's been only very low numbers, and it was it looked significant, and I just wondered, is there any reason why?
There's no one
particular... Is there a common reason? Is there a common core reason why? Has there been a change that has taken place relating to finance?
There's no change in actual processing of finance. I think sometimes the issues, because it's individual cases, is where people are sometimes unwilling to accept that there are charges. That's cropped up quite a few times. So people have sort of refused to pay towards care, and there's sometimes been delays in payments, and then that when people are challenging that, and it goes to a separate stage where they've got to provide information on their financial background and things that are associated with it, and the challenging the fact that they've got to pay for care have led to a couple of complaints. So there's no particular trend, there's no change in our processing, and there's not a delay in that sense. It's mainly about communications and people understanding when they're taking up services that there is a cost attached to them at times that they've not been expecting.
Right, is there any way to change that, to provide more earlier information so that they know that there is going to be a charge involved?
In 3 cases that I can recall that they had been provided that information, it was more a challenge round that they didn't want to meet those costs.
Okay.
So then a complaint's been generated because of that.
Thank you.
Thank you. I don't know if it would be useful to actually put down the number of users in the system, because actually they seem extremely low numbers in relation to complaints in comparison to how many people are actually helping and serving. So I don't know if that would be useful for future reference to actually say, you know, we've had, you know, we've got 20,000 people on our books at the moment, and therefore in comparison, it helps us to have a better understanding, I guess.
Yeah, certainly that's something I can discuss with Kath and how that's represented.
Yeah, no, it's superb. I think, as I said, it looks really positive, and they say if there's only 300 users in the system, then it's quite serious. But you know, I'm sure there's a lot more than that. So, Councillor Hutchinson.
Thank you, Chair. There's been the move towards personal budgets for social care. I was wondering how those were, whether there were any, how smoothly those were being administered, whether those were giving rise to many complaints or disputes compared to the people who weren't on personalised budgets.
That's not something that's trickled through to us as yet, so I wouldn't want to comment on that.
Okay.
To be quite honest, I can only deal what we actually see. I can put that across to a member of the team to answer you separately after the meeting.
Thanks.
Thanks, Councillor Hutchinson. Can I just ask a general question in relation to information on the website as well? And it probably refers to Kath in your new role, but in terms of some guidance as to people applying into the system for the first time, some people aren't always aware in relation to if they've given money out to relatives, or if, you know, in a short space of time. Now we've had a complaint through our office in relation to they gave a relative an amount of money which had a negative impact in relation to the claim. So I don't know if it's worth putting something on a website somewhere saying, actually, if you are a first-time claimer, you will need to, if you've given away some money, you will need to do X, Y, and Z. And I don't know what the answer is to that, but it's something that I think a lot of people aren't aware of, I think, out in the general public.
Yes, thanks, Councillor Barbara. We'd certainly have a look into that, and I'll pick that up with Lynn and the team as well.
Superb. Brilliant. I don't think I've got anyone else indicating to speak, but there's always famous last words. Apart from Mike would like to have a word. You're on silence, I'm afraid, again.
Councillor Barnes has put a question in the chat.
He has. I'll read it out.
About procurement.
Yeah, I'll read it out. Do complaints feed into future procurement in both the tender documents, the contract, and/or the granting the tender to a care provider?
I think what I would say to that is it's because of the way that we keep the learning logs and the information where there's been problem with care providers. Obviously, that's then recorded. And that would depend on the number of instances, how it would feed into that, because you may find that there's a situation that's occurred, you know, in abstract, you know, it's unique just to a member of staff that's with a care provider or conduct. So it's that information's captured and it's fed through that way, but it wouldn't necessarily influence, you know, the entire procurement process, but it certainly influence how they would then ask for a company to manage services going forward if they were successful at a tender process again. So I think, again, it's because we're looking at the exceptions with the complaints, all the information is being utilised and fed back, and it would obviously be weighed into anything that would, you know, if it was a serious matter, be considered at that point.
Excellent, thank you. Mike, is that a historical hand?
No, Chair. It's just picking up on Councillor Hutchinson's point about Healthwatch. In previous years, we've had Healthwatch along to talk to us generally about issues that have been raised with them, both on the NHS side and on the social care side, and also about the advocacy service that they run in supporting people who are making complaints. And we haven't got it on the work programme this year from a quick glance. And if members are happy, we'll contact them and build them in perhaps early in the new year to come and have a general discussion with you.
Yeah, super. That sounds like a plan to me. So nobody has any other comments to make on your report. So so you've got away very lightly. So thank you for presenting that. It's normally a lot tougher than that. So you're more than welcome to stay, but I'm sure you have other things to do if you need to leave and prioritise. So, but thank you once again for attending and producing the report. So thank you for that.
Thank you. Bye-bye.
Bye-bye. Excellent. Item number 6 is suicide prevention, and all the reports from Debs and Eugenie. So welcome to our scrutiny once again.
Thank you.
Brilliant. Thanks, Councillor Blackburn. I'm just going to hand straight over to Eugenia, who's leading on suicide prevention for us. And this was really, do you remember, I think we had a discussion about a year ago, Chair, and this is really a bit of an update on where we've got to with suicide prevention. So over to you, Eugenia.
Thank you, everyone. I'm just going to share my screen, if I can work out how to do that. Here we go. Right. Can you tell me someone if they're there?
Yeah, we're there.
Okay, great. Let me just put it on slideshow, and then it should be even better. Okay, great. Thank you very much, everyone. Really nice to meet you. My name's Eugenia Cronin. I'm a consultant in public health. I'm going to update you on the suicide prevention strategy, which I know you know about because it came to scrutiny, I think, last August, and I think you were sent the action plan following that. So just a couple of things to say just before we get started. This is obviously a difficult and sensitive topic. There are statistics in the presentation, but I wanted to preface that by saying every single suicide is a tragedy, and we want to eliminate suicides completely. I always start with sources of help, so I've just got a few slides at the start to do that. So this is the West Yorkshire Suicide Prevention website, where you can click on Calderdale and get support, and the URL is on the side there. Got the Samaritan's phone number and the email address as well. So this is a really good source of support. There's a local campaign called Check In With Your Mate. So you can see that, you know, we've got quite a few images there that are being circulated. So it's very much focusing on men. And when you get the slides after the meeting, you'll be able to click on the link there. And finally, there are some resources from the Samaritans, who are obviously a brilliant source of support. There was a film that was done by Verdegrees locally as well, and you've got the link there. And there's the little book of Minding Your Head, which has a rural focus. So just a few resources there. Now, in terms of, I'm just wondering if I can take out all the photos so I can see the slides. It's not going to let, oh yes, hang on. Excuse me, right, done. So this presentation is really in four chunks. So you've got some facts, some myths, what are we doing in Calderdale to prevent suicide, and what we can all do. So some facts about suicide. You may well be aware that more men die by suicide than women. If you look at different age groupings, suicide is most common in the age 45 to 54. Among men aged 20 to 34, suicide was the leading cause of death in England and Wales, of deaths registered in 2020. And in terms of children and young people, those aged under 25 actually generally have a very low number of deaths generally. But rates of suicide in this age group have generally increased in recent years. And on the right there, you've got a graph which shows a general and very welcome decrease over the years since 1981, with a bit of a rise, you know, I think that's around 2019. Suicide and socioeconomic deprivation are strongly associated. In terms of the association with socioeconomic status, also that applies to accidents, alcohol misuse, and drug misuse as well. And we know that from international studies that most deprived men are twice as likely to die by suicide as the most affluent men. Now, in England, suicide risk has been associated with unemployment, and we've seen substantial increases in suicide during periods of recession, especially among men. And actually, this piece of research was really about the kind of north-south England disparities, and it pointed out that the gap between, it pointed out that suicide rates have generally decreased since around 1998 in both sexes, but a gap has emerged for men between 2010 and 2015 as suicide rates climbed in the north. And speaking of those, there are these regional differences that you can see there in the right-hand graph. And you can see, actually, it's quite interesting that the grey bars refer to 1981 to 1983. And you can see in those days that actually London had the highest rate, and now it's got the lowest rate across those regions. Yorkshire and the Humber is now, well, for those years, which were 2018 to 20, it has the highest rates. So we know that people living in the most deprived areas of England have a higher risk of suicide than those living in the least deprived areas. And in fact, if you look at the most deprived 10% of areas, in terms of deciles, for 2017 to 19, there's almost a doubling of the rate between the most deprived 10% and the least deprived. So in Calderdale, these are rates per 100,000 again. You can see that we can see a steady increase. Now, Office of National Statistics released data on registered suicides just a few weeks ago, actually. And these are rolling rates over 3 calendar year periods based on date of registration of deaths. So as you can see, we do see a steady increase in Calderdale. Calderdale's rates are also worse than Yorkshire and the Humber and the England averages. And I think you can see with Yorkshire and the Humber and England a kind of a bit of a stabilisation of rates over the last few years. Just something to note is that there is a caveat in these stats in which the difference between 2018-20 and 2019-21 might be artificially inflated because of delays at the coroner. During 2020. I can come back to that if people are interested, but it doesn't make a lot of difference to the overall picture. So that you might remember some, this was discussed, I think, last time, the suicide audit for 2016-18. This is for Calderdale. Around 2/3 of deaths were in men. There was a much higher proportion than the general population in terms of being unemployed. Most individuals lived alone and were single. Around 30% had been in touch with general practice in the preceding month, and that was 10% for mental health services. 78% had a diagnosed mental health condition, most commonly depression. Most occurred at home. And you can see the most common adverse life events there, so I'll just let you just read those. So it's important to think about some myths about suicide. It's important to be aware of these. And both the World Health Organization and this list actually comes from the Samaritans, but they're very similar lists. And I'm not going to read all this out to you, but I will pick out a few. If a person is serious about killing themselves, then there's nothing you can do. Actually, suicide is preventable. Another one is you have to be mentally ill to think about suicide. That's also a myth. Talking about suicide is a bad idea, as it may give someone the idea to try it. Also a myth, and I'll come back to that because there is some training that I want to talk about in a few slides. And people who say they're going to take their own life are just attention seeking and shouldn't be taken seriously. So that is another myth. So what are we doing in Calderdale? And this is, I'm sure, where you want to focus. So the vision in Calderdale is for Calderdale to be a place where suicides are eliminated and where people don't consider suicide a solution to the difficulties they face. Also a place that supports people at a time of personal crisis and builds individual and community resilience for improved lives. So the next thing I just want to remind you of are the 7, I suppose, planks of the suicide prevention strategy. And then I'm going to pull out some examples from each of those. So we want to reduce access to the means of suicide, tailor approaches to improve mental health in specific groups. We want to do better on research, data collection and monitoring. We want to provide better information and support for those bereaved by suicide. We want to reduce the risk in high-risk groups. We want to do communication and engagement. And of course, we need leadership and governance to be very pivotal in all of this so that the work is embedded across governance structures. So the examples I thought I would give you are the Pathways Project, High Risk Places work, support from Leeds Mind, mental fitness sessions, community mental health transformation, repeat of the audit, Papyrus training, and finally the new suicide prevention strategic group. So I'll just go into those now. So the Pathways project is where we're working. This is something that we've started in the council to work with key agencies to understand what happens when someone is taken from a high risk location to a place of safety. So essentially we want to ascertain what support is offered. This work is quite complex because there are a number of agencies involved and the pathways are complex. As part of it, we're piloting a new system whereby the police ask mental health services if the person is receiving services, allowing us to identify those who aren't. And ultimately, we'll identify gaps in provision, we'll sense check these with people with lived experience, and we'll make recommendations for service improvement. So far, you can see some of the themes there are around information sharing, capacity in some of the services, and whether the person has a diagnosed or a diagnosable mental illness. The next one I wanted to tell you about is some work we're doing with high-risk public places. So we commissioned urban scale interventions to explore new and creative approaches to those areas. And USI engaged with over 70 individuals. I'm sure some of you may have been engaged in some of that work. Through interviews and workshops between February and August this year, and they've recommended a range of short and longer term physical, cultural and social interventions. And what we'd like to see here is the creation of a virtuous circle where positive cultural and business activities around the area will lead to greater footfall, which in turn leads to more positive activity, a greater number of people passing through the area, which means less opportunity for an individual to get into a dangerous space and a greater likelihood of intervention and support if they're in distress. And there is actually evidence that reducing access to high-risk places does not lead to use of other places. I mentioned suicide bereavement. We know that those who are bereaved by suicide have greater suicide risk themselves. So we need to support them. And we have a service in West Yorkshire to which family and friends of someone who has died can access, and we actively refer. So that is done by the police, and you can see the contact details there as well. Mental fitness sessions. This is very much with men in mind. So these are delivered by State of Mind Sports. The objectives are to promote positive mental health. The content includes suicide prevention and looking out for those who might be struggling, much in the same way as the check-in with your mate campaign. And we're arranging currently for a range of workplaces to access those. And then there is, there's quite a bit around community mental health transformation. So I've just got a couple of slides, but without going into reading all of this out to you, there is significant investment coming into West Yorkshire from NHS England, and you can see the kinds of focuses they've got there. There is also, as part of that, an increased focus on some particular roles that are within primary care, so social prescribing, link workers, physiotherapists, paramedics, pharmacists. But of course, we have a lot of work going on locally as well. So we have community emotional health and wellbeing support, which is something that is, I understand, fairly new. So we have 11 whole-time equivalent community emotional health and wellbeing workers employed by Healthy Minds. They're going into local areas, following a letter, I think, that is sent introducing the programme. And the idea is that general wellbeing support is offered to households. It's a 2-year pilot, so each primary care network or locality will design its own offer. So it's not standard, based on the needs and assets of the area. The Staying Well hubs are very connected to this, and I think these have been going for a few years now. There are 3 hubs in those anchor community anchors, rather. The whole of Calderdale is covered. Referrals can come from services such as adult social care or social prescribing link workers, or actually self-referrals are accepted. And you can see on the left, there's a quote from someone who did exactly that. And the idea is that the workers meet with an individual to find out what they need, and they work to make people feel less lonely and isolated. And you can see some of the services there. But apparently it depends very much on what's wanted. And I understand hot off the press that in the delivery of the influenza and COVID vaccines to household people this year, primary care networks will be distributing the Staying Well postcard, so that captures all of this, as well as the cost of living postcard. Healthy Minds is a really important part of the whole system, and these are some of the services that they offer: safe space, out-of-hours support for people who are 16 and over, who are in distress, welfare rights support, the mental health project for Black and minority ethnic groups, project called Rashani, Walks for Wellbeing, and Time Out Calderdale, which is for young people. And then for children, young people, just to give you a quick rundown of the kinds of support there is for emotional health and wellbeing. We've got mental health in schools, where each school has a named contact. The training around that's offered as part of that includes suicide awareness. There are parent workshops as well. Topics include managing emotions, social media and wellbeing. And there is the other stream of work, which is mental health support teams, which are NHS England funded. And they are in some of the schools, or some of the schools have been involved so far. And I think that's building. And of course, you have the school nursing team as well, which provides advice, assessment, early intervention and referral for different kinds of issues around emotional wellbeing. Of course, we have the Open Minds CAMS offer, which provides telephone, online, face-to-face support, and signposting depending on the nature of the referral. And crisis support is offered by the first point of contact and by night owls. So only a couple of slides to go. We are repeating the suicide audit. We're working with Kirklees and Wakefield to revisit the coroner's data for 2019 to 21. So that will give us 2016 to 18, followed by 2019 to 21. Really what this work is a retrospective exploration of the epidemiology. Slightly fancy public health term there, but that's what it is. And we will compare, obviously, with the earlier findings. But really what we want to do through that is identify risk factors and ways we can do prevention, ways we can prevent suicide. I said I'd mention the Papyrus suicide prevention training. So this is being commissioned, or just being commissioned now at the West Yorkshire level. Papyrus will target cohorts of staff and volunteers. It's suicide prevention training per se, so it should help everyone start a conversation about suicide and increase alertness to suicide. And you can see the target groups there: staff of GP surgeries, social prescribers, union reps, line managers in major employers, and so on. Lots of different kinds of staff groups that come into contact with people who may well be struggling. And finally, in terms of that group of 7 things I was going to tell you about, We are developing a new suicide prevention strategic group. We have a current group, and it's actually a brilliant group. It's very large, and most members, according to a straw poll that we did recently, talking to them, they want to come along and network and share information. So that's absolutely brilliant. But we do need a group that's focused on delivering the strategy. So those will be people in strategic roles across the system. So it'll be a smaller group focused on the action plan. So the action plan is currently being refreshed, and really for two reasons. Some of the actions are completed, so we can take them off, but we also want to capture the additional pieces of work that have started to happen that aren't in there. But it will have those same 7 headings. And this is really the final thing I wanted to say before very happy to take some questions and get your views. What can we all do? So there is this Zero Suicide Alliance training. I did it actually quite recently. I did the 20-minute version. It's online. It's free. It's recommended really for anyone aged 16 and over. And it helps you be able to have a conversation. And as they put it at Zero Suicide Alliance, anyone can potentially have a life-saving conversation. So that is all I wanted to show you in terms of slides. I'll stop sharing and come back to the group.
Thank you for the presentation. That was really extremely useful. I've got Councillor Barnes.
Sorry, Chair, I didn't realise how dark this room was, but it was very interesting having the first half an hour in the back of a moving vehicle in order to get here. A couple of things. One very specific, which is on one of the slides you mentioned the audit with Wakefield and Kirklees.
Yeah.
Is there any particular reason why it's Wakefield and Kirklees? Because Wakefield isn't exactly the nearest local authority to Calderdale, is it?
I think that might be an error. I think it might be Bradford and Kirklees. Sorry about that. Yeah, it's local authorities with whom we share a coroner, essentially. So right. You're right. Thank you for pointing that out. Yeah.
Okay. Breathe sigh of relief. Second thing is, I'm just going to lower my hand. So the second thing is, I think there sounds to be some great work, and there's been a lot, and I think we have to applaud how far we've moved on in the last 12 months since we saw this. So really, please don't take this anything other than very positive feedback. I think some of the comments that we made when we discussed this before was that when people are in, and I'm going to apologise for the use of the word, in the system, in the process, there is the work is really in there. I think I remain concerned about those that aren't in the system, those around the periphery, those that are coming in, because one of the key issues is going to be the PCNs and the GP surgeries. And going back to what we found out, if you can't access a GP surgery, if the individual on the other end of the phone if you're being triaged by somebody who isn't in Calderdale on a phone line from 150 miles away, I'm really still uneasy on that front, and I think that feeds into some of the work that this committee is doing in terms of the GP access. But if NHS England are saying that your first port of call to a doctor is a telephone triage, if it takes you half an hour to get through to the doctor and you're going to hang up, you're not going to wait for that triage phone call to come back. You are then, you're not going to be picked up by all of the great work that is being done by yourselves afterwards. And I still think, look, I don't know the answer to it. I'm not sure anybody knows the answer to it, but it's still I'm still uneasy with that.
Yeah.
I've just got a hand up. I don't know if Debs wants to go in on that one.
I did. It's a really important point, Councillor Barnes. And you know, Eugenia clearly showed, didn't she, that the previous audit showed that 78% of the people who took their own lives in that previous audit were in contact with you know, did have mental health, diagnosable mental health issues. I think there's a couple of pieces of work that Eugenia mentioned that really are really about trying to sort of get the system working better in terms of getting people, identifying people that we haven't identified. We don't identify potential until it's too late, and they are the pathways work that Eugenia mentioned. So where people are attending at public places where it appears that they're in distress, that we get a system so we make sure that those people are followed up properly and get into a system properly. So if they're in contact with mental health services, we absolutely alert the services that they've been in distress, and we fill the gap where they haven't been. And that's not requiring a GP in any way. That's about getting them into support sooner. And the second piece of work is the work that Eugenia mentioned, the community health and wellbeing workers, which is part of the transformation programme. And this is in sort of parts of the borough. It's starting in parts of the borough, and it involves knocking on people's doors, going to areas where we know there's a higher prevalence generally of mental health conditions and mental health challenges. And it's actually about getting out there and knocking on the door and talking to people. And the community health and wellbeing workers actually come from those local communities as well, so they sort of understand the community, know the community. And again, that means that then you're not having to get a sort of a conversation with a GP or a referral for a GP. It is really important. I mean, you know, you're absolutely right, Councillor Barnes. GPs are critical in all of this system, but there are some things that we're trying to put in place that where you get a different sort of access, if that makes sense.
Check, let's just come back. So what we're talking about is outreach programs, or instigating, involving in some outreach programs. Sorry, Debs, it's disconcerting because you look like a cyber man with the red lights there. Sorry. So what we're looking at is outreach programs. Is that right? Thank you. Thank you for that. Appreciate it.
Does this also tie in with the Healthy Minds pilot as well, Debs? In terms of knocking on doors?
It's the same thing. It's part of the mental health transformation programme. It's hosted by Healthy Minds. Absolutely. Yeah, you're absolutely right.
Super. Councillor Hutchinson, please.
Thank you, Chair. Just looking at trying to deal with the risk factors that contribute to this. You made the point about rising levels of suicide at times of economic depression, and that unemployment is a risk. How big a factor is debt, whether that's from unemployment or gambling or other issues? And I know there's some very good work being done by a couple of providers within Calderdale. Are we doing as much as we could be doing to try and help people manage their debt, to head that off at the pass? I was always taught that people in depression who had depression were at their greatest level of risk as they were responding to treatment from depression, as they developed the sufficient energy and motivation to carry out the act of suicide. Is that the case? And if it is, do we have the measures in place to actually assess or support those people as they start to recover from the depths of depression? And the other thing there is quite an association with abuse of alcohol and drugs, and we've not really nailed the dual diagnosis services so far. is there any light at the end of the tunnel in terms of having a dual diagnosis service that people can access, rather than at the moment that they have a tendency to be bounced between the two because they don't meet the commission criteria for each one individually?
Shall I have a go at answering some of those?
Yeah,
I might, Debs, I wonder if you could tackle the dual diagnosis one, because I know you're aware of Neve's work. So really interesting questions, and there's a lot there. In terms of how much a role debt plays, I don't know if we can quantify that, but it is one of the precipitate, it's in that list of life events that can have occurred prior to someone dying by suicide. So it certainly is there. And I think in the work we're doing around cost of living, it will, there's quite a lot of work going on to promote all the support available around cost of living. So I think it will be within that context. And in fact, we showed at the last suicide prevention group, we showed the webpage that Calderdale Council has for that, which is absolutely brilliant. Lots of support. And in fact, our West Yorkshire representative wanted to share it with others, because they were saying, are others doing this? So I think, there is support for people with debt. The issue about a particular vulnerability at the point of starting treatment for depression, I hadn't heard of that. I suppose if, I would expect that the clinicians who are providing the treatment would be aware of that. So I think that would have to be monitored within the kind of clinical episode. But I'm very happy to look into that and perhaps communicate afterwards to see if there's anything particular that we should be doing.
Thank you.
Can I come in? Yeah, please. Thank you, Chair. Just a couple of points, and just before I move on to dual diagnosis, just the debt support and cost of living. You asked Councillor Hutchinson, is there enough? And I think the answer to that is no. I think. To be really honest, I think it's important to say that I think there is a risk at the moment. I think what I would say is that there's some really, really good conversations now happening between the local authorities in West Yorkshire, the Health and Care Partnership that works around the Integrated Care Board, and the Combined Authority about just what are the things that we can do. So the Health and Care Partnership, I was involved in delivering a presentation to that partnership board a few weeks ago, and following that, I'm involved with colleagues from the Combined Authority in the Health and Care Partnership at West Yorkshire level, convening a conversation, and we've actually identified we're not going to be able to sort the cost of living crisis out between us in West Yorkshire, but actually we've identified 4 priority areas that we want to explore. I won't go through what they all are, but one of them is the increased risk of suicide and poor mental health problems. Previous recessions, as Eugenie has told us, previous economic crises we have seen increases, I'm afraid. So there's something about having that focus about what we do collaboratively at West Yorkshire level as well. In terms of drugs and alcohol and dual diagnosis, you're absolutely right that there are still challenges in relation to. We do know that we do know we have an increased risk of people taking their own lives in relation to drug and alcohol use, and we also know that we do again in some of our high risk locations, drug and alcohol misuse is a factor in people attending with suicidal thoughts. What we are doing, as you may be aware, Councillor Hutchinson, is that we're actually developing. We're actually working on the local implementation of the national drug strategy, and we're getting some additional resources. In that it's actually going to cabinet on Monday. day. And one of our priorities for transformation using that resource from government is to really improve our dual diagnosis pathways, outcomes for people with both drug and alcohol misuse and mental health issues. So that's one of our key priorities for that. So I'm hopeful that we'll be able to make some real improvements in that with that transformation and that additional resource.
Thank you.
Thank you, Deb, for that, because I was just picking up on the PCN sending out something about the cost of living. It's something Mike Lodge might need to pick up, because I'm on the working party for the cost of living group. So it might be just something we pick up on that as well, so we coordinate. Yeah, superb. Yeah, it's got that. Councillor Kingston, please.
Thank you. I've got a few thoughts. One is I didn't hear mentioned Andy's Man Club again, and I brought that up previously, and I just want us to be more aware of that and directing people to it. And also I had the pleasure this week of listening to that amazing BBC Radio Sounds with the Halifax Hikers, who are also clearly a group that have self-established for mutual mental health support. And I just wonder, how much work do we do on identifying, given that social isolation is such a significant factor in our figures, how much work do we do on identifying local social groups and societies that we can direct people to who are experiencing social isolation? You know, these postcards that we're sending out, are we including, naming these groups on them, directing them to them? How much are we, because these will be groups without money for advertising, how much are we supporting them with people finding them? That's one of my questions. And then my other is the 20 to 24 years old. That group was one of the vulnerable groups. And I just wondered, do we know any more about the particulars of why that group in particular, there's a higher level of suicide rates in that group? Is it because they're post-education and like life is hitting they've lost those social contacts that they have with their peer groups through school and universities? Is that a factor in that? Sadly, you know, we've lost so many of our youth services, and that seems significant in that. And what more could we be doing on our tiny little budgets to work on setting some things up for young people? That was it.
Yeah, super. Deb's kindly puts her hand up, so I'm hoping she's going to come back on some of those things.
I can't answer the final question, Councillor Kingston, but you, Jane, you might be able to. But in terms of, you're so right about the amazing assets we have in our communities, and, you know, groups that set up and spring up and support each other. And absolutely, Andy's Man Club, Noah's Ark as well in this area, are fantastic. We've got some amazing organisations, and absolutely. In terms of making people aware of those, we are doing some work. There's a few pieces of work that we're doing. So one of the things that we're doing is we're exploring the development of what I would call an integrated community information directory. So we've got lots of community information directories, brilliant, all of them. And at the moment, you sort of have to put yourself into a sort of a category to know which one to go to. And so we're doing a bit of work to think about how can we bring all of those together so that it's really easy for us, for people themselves to look at what's available, but actually for every single one of us to use that to have what I would call a connecting conversation. So when we're meeting people, when we're chatting to people, something that we can pick up on our phone and just put something in, I don't know, Skirkett Green and mental health or community group or whatever, and it'll come up with all the different options that there are available. And that's a piece of work that partners are working on at the moment. And then the other really important work around the sort of social isolation and all the people being aware of the things that are going on. Very much that's what our fabulous social prescribing link workers do, those community health and wellbeing workers that I mentioned. Again, the idea is they're aware of all the different things that are going on in their local areas. And also our fabulous Staying Well hubs as well, which again, the idea is that they help connect people to the things that are going on in their community and being area-based. They know the stuff that's going on. I think there's more to do, Councillor Kingston, and that's why we want to look at developing that integrated directory. But we've definitely got the beginnings for sure of that sort of approach.
Thanks, Deb. Jeannie, do you want to come in on yeah?
Yes, please. No, just to say, Councillor Kingston, we're really well aware of Andy's Man Club and the fantastic work that they do. I couldn't mention everything, so I was just trying to give a flavour of some examples. But yeah, they're very much part of the system and very, very much referred into. So I won't repeat the stuff around the Staying Well hubs, but in terms of those, I think a couple of the stats you were mentioning. So the under 25, the numbers are actually thankfully really, really low in that bracket. But we absolutely mustn't be complacent about that. And there is all that support going on around younger people. And I completely echo, I've seen it in other local authorities as well. The loss of youth clubs is something that is a loss, in fact, for the kind of middling kind of age group, I suppose.
Thanks for that. I'm actually going to send you some details with an organisation called Tempus Nova, which is they work with the prison service and to rehabilitate people into the communities. And I think it's a real key. I think it's an area that we perhaps need to focus on equally, I guess, in some way, so that we don't end up. Please do. No,
as we're setting up the new suicide prevention strategic group, that could be really useful.
Superb. I will. Right, Councillor Brundell, please.
Thank you. My first question touches slightly on what Councillor Kingston's just touched on. I'm aware that transition period between coming under youth services and then kind of aging out of them at 16 or 18 can be particularly difficult for people, as they have a new team perhaps and new contacts that they aren't as familiar with. Is there kind of a concern around that in Calderdale, and is there any support in particular around that period to make sure it goes smoothly and that they do continue to seek support and they don't kind of drop off the radar somewhat? And second question would be, I know it was mentioned that the suicide risk in those who've kind of lost someone to suicide is high. Is there any support in particular for those that have perhaps witnessed a suicide or attempted suicide? Is there kind of follow-up on, if someone has helped someone out of that situation, is there follow-up support for them? As I imagine it must have quite a profound impact mental health wise to have witnessed or helped in that situation. Thank you.
I'm happy to take those. So the transition, do you mean if you're a client of CAMS, for example, and then you reach 18 and that problem of transition, which we know can be an issue in other areas, is that you're talking about young people in that position?
I think, CAMS is what I'm familiar with and what I know anecdotal friends that are familiar with, but I think in general that sort of issue of the services are quite separate for youth to what they are for adults.
I know I might need to come back to you about what work is going on, particularly around that transitionary period. But I know from the work we're doing on pathways that when we ask the question about, so someone comes to a high risk location, what happens depending how old they were, there's a there's no hard and fast rule. So it certainly wasn't that, well, if they're 18 and under this way, and if they're 18 and over, it was much more nuanced than that, and much more understanding of where someone was at. So that was a very encouraging kind of observation. But I think we'll come back to you on the transition thing more specifically. In terms of people who are bereaved, again, actually, I think I need to come back to you about whether someone who's witnessed a suicide would be able to access that service. But I do know that we're doing various pieces of support for staff of the council, actually. So we've got some support coming in for staff of the council who may have witnessed something traumatic, and we're doing some work with the police as well at the moment. So yeah, we're certainly trying to support that. But I'll come back to the point about someone perhaps outside being a staff member who might have witnessed something.
Thank you.
Thank you for that. And Councillor Pritchard. There we go.
Sorry about that. I'd like to actually talk about people who are not in isolation, who are in families. Got some personal experience of this because my father tried to commit suicide 4 times. And as a family, we managed to get him before it became a terminal issue. But I'm pretty sure that the services that are on offer now for those people who've sort of witnessed a suicide would be extremely helpful, because they weren't around when I was a child. And we mustn't forget the families of the people who are still alive, because it has a traumatic effect on them as well.
Okay. Yeah. It's a really good point. So yes, that's going to be something where a trauma-informed approach could be really helpful. I think that's something we haven't thought about, actually. And so you know, obviously there will be that will affect a number of people. And I'm not sure there are any services actually for people who are part of the family or, you know, close friends of someone who has attempted to take their life. So let me bring that up in our suicide prevention group as something we need to look at.
Councillor Hutchinson.
Thank you. You didn't mention it in the presentation, so it might not be of any relevance, but is there any difference in the prevalence of suicide or attempted suicide in different cultural groups? And if so, if there is, does that have any influence on the strategy and the way that it should be delivered to take those cultural differences into account?
Yeah, I think it's another really good question. I think probably we know something at a national level around. We will have, you know, enough statistics to be able to know something. I think locally we don't, because I think some of that data is not very well collected, actually, and that is one of the things we're working on. But it's certainly, you know, it's a bit sort of chicken and egg, because if you can't, you know, in the audit, we of course will try to gather that data, but if it hasn't been collected, if ethnicity, for example, hasn't been collected all the way through the process of the coronial inquest, we don't know. So it's a challenge to know. So I think we probably do have some national statistics and epidemiology, but we don't know what that looks like locally.
Whether we know it or not, are we sure that the services that are available can offer that cultural sensitivity?
Yeah. So a couple of answers to that. One is, in terms of suicide bereavement, we need to make sure that we are. The other answer is that I suppose it's about how services respond generally, isn't it? How health services, how social care services respond generally. So if they are responding to cultural and ethnic diversity appropriately, we would hope that their response in terms of suicide or someone struggling would be appropriate, wouldn't we? But I think in terms of those specific services for suicide bereavement, I think we'll need to look into that.
Thank you.
Thanks. Deb, you've got your hand up. Is it a historic hand, or would you like to?
No, it's not. If it's okay,
fine.
just if it's okay, I didn't put my hand up for this reason, but I think that's such an important point, Councillor Hutchinson, that sort of cultural competency of the services, and I think that's something we can definitely take away, isn't it, Eugenia, and have a look at through the suicide prevention group. So thank you for raising that. One thing I do know is that because I'm doing at the moment some work around Gypsy Roma traveller communities, and I do know that the suicide rate in Gypsy Roma traveller communities is significantly higher than the non-Gypsy Roma traveller population, and there has been some really helpful work published actually recently, and Leeds Gate, who cover West Yorkshire, ensure that we have the voice of Gypsy Roma traveller communities, have done some really important work around preventing suicides, particularly the sort of specific cultural issues for that community, which is really, really important. So that was that's sort of just something I was going to say once I heard what you said, Councillor Hutchinson. But the reason I initially put my hand up actually was just to thank Councillor Prashad for that really important point that she made about the support for family members, and actually it reminded me that and Eugenia did say it in the presentation, but it's reminded me, one of the things that we are doing is really working with people with lived experience of suicide, of family members who've attempted to take their own lives, and how important it is to hear that voice, because sometimes the things that the services that we've got in place, or the things that we're putting in place, aren't reflecting some of those really, really important issues. So it was just to thank you and just really reiterates how important it is that we hear from, from people with experience of the broad, all the different elements of this horrible, and really challenging issue. So thank you.
Thank you, Deb. So Eugenia.
Yeah, just to add to that, really, that in fact, if you've been bereaved by suicide, I imagine it might be similar if you've been around someone who's attempted to take their own life. There is actually a lot of stigma that people experience. So it is really important to be aware of that, and to bring it out into the light, actually, so that we can all have these conversations.
Thank you. Certainly, last year I attended a mental health awareness day in the Minster, hosted by the Interfaith Group, and I think that was a really important session. I think would very much want to work alongside them moving forward. And I think this is a real key topic. This is not going to disappear. We need to work with you, and we want to work with you, and we'd very much welcome this coming back, in a regular intervals, so we're made aware of differences, and equally just ensuring that where you feel that there is a wider issue that is reported to the Adult Safeguarding Board, that we just need to be working together, because times are going to get tough, and people are going to struggle, and in all elements. Eugenia, absolutely, thank you very much for the presentation. Really well presented. Really some extremely important points and things that we can take upon and work with you, and that's the element. So thank you very much for the report. It's not going to go off the agenda. You'll be pleased to know. So we'll be working with you. So
thank you, and thank you for all the ideas and really excellent points that have been made. We'll be taking those away. Thank you.
Super. You're welcome to stay for the last item, but equally, if you've got more pressing things, we shall say good evening.
Thank you. Thank you very much.
Yeah,
good evening. Bye.
Thank you very much, members. So now to the work programme, and I'm going to give Mike a little bit longer this time than his 30 seconds. You can have a minute.
Thank you, Chair. I think the main business we need to discuss under this item is the establishment of a joint working party for Children and Young People Scrutiny Board on the Equal Care report that I believe we have circulated, and we have also asked for people who are willing to serve on that joint working party. So just briefly, to not to go into the issues at all in the report, that's for the working party to do, but the report was published and launched recently.
Councillor Baker and Councillor Showcat both requested scrutiny review, scrutiny involvement in that. I was contacted by Robin Tuddenham, who supports the involvement of scrutiny in that, and has talked to me about the suggestion that it should be a joint working group of children and adults. Anne Flanagan, the interim director of Adults and Wellbeing Services until this week, has briefed Councillor Blackburn and Councillor Evans and as the chair of the Children's Scrutiny Board and myself and Bella, and gave us some really useful insights into what she knew and what was going on. So as a consequence of those discussions with the two chairs, we've asked for nominations, and quite to my slight surprise, we asked for 3 from each of the 2 scrutiny boards, and we've got 3 from each of the 2 scrutiny boards. 3 isn't a magic number. If there are other people who want to get involved, then we can certainly look at how the composition of those groups. So from this scrutiny board, Councillors Blackburn, Hutchinson and Showcat have put their names forward. We're going to have the same conversation next week with the Children's Scrutiny Board, where 3 other members have put their names forward, and we hope to arrange a first meeting of that group in the week beginning the 17th, so we can actually get moving on this. In addition, following a conversation with Zora Zankudi, I've had a conversation with Tahira Iqbal and Sale Suleiman from the neighbourhoods team, and that was just the other day, and that was really valuable. Now I'm updating Councillor Blackburn and Councillor Evans, I hope, tomorrow about that. And they have both offered to provide support to the Working Party, to support myself and Bella in supporting that group from their particular. There's actually significant and massive both experience and knowledge. So that's really helpful. And Kath and myself are catching up tomorrow morning to touch base on this, but also to start to talk about making sure that the work of the council in responding and the work of the scrutiny board in looking at that response is coordinated in terms of timeframes. So it's important that people who are looking in on us on this important bit of work recognise who's doing what and where and when. So that's I think that and I'm sure we'll carry on having those discussions. The only thing that I would say as an observation about we have 6 members put forward. We have only 1 female councillor who's put their name forward, Councillor Durans from CYP, and I'm just wondering whether we've got whether we perhaps need a slightly more balanced group in terms of gender. So if there is anybody who either now or by all means contact me and talk to me and ask what's involved by email or phone, I think that would be really helpful.
Thank you. I think Councillor Prashad is going to volunteer herself, hopefully.
Well, I did have a conversation with Mike about this, because I should have been going into hospital for an operation next week, but that's now been cancelled and put back to November. So if you do want some more female support, then I think I can probably help out.
You've volunteered yourself, thank you. Councillor Hutchinson.
This wasn't about the that work.
Okay, I'll just put you on hold for the time being. I think, Mike, you've summarised that extremely briefly. I don't think there's anything further to add, and we'll update members accordingly as we move forward with the working party. So, Councillor Hutchinson, if you'd like to come back in.
Discharge to assess is the key part of the transition of trying to actually keep hospital services running by making sure that patients are discharged home, or preferably home, or to another setting, and then they're assessed as to what reablement and other services are needed to continue their care. But a couple of years ago, Health Watch and the Red Cross produced a report that strongly suggested that it was often not actually working terribly well, that people were being discharged and then not assessed. And I really, given that some of that evidence came from Health Watch, Calderdale and Kirklees. So given that it's such an important feature of the health and social care services running as smoothly as possible, I wondered whether we could actually look into whether it is, whether it is operating as smoothly as it should, what issues there might be, and Health Watch may be able to feed into that. I would hope.
Thank you, Councillor Hutchinson. Mike.
Just to say, yes, I think we should have had that on the work programme before, and we'll add that to the work programme and talk to both NHS colleagues and Catholic colleagues about that item. So we will do that. The only other thing I wanted to mention is that a good number of you met informally at 5 o'clock to talk about the work on general practice that you undertook last month. And I'd like to suggest we add that to. I'd hope we'd be near to a final report by the November meeting, but even if we're not, I think it's important that you have an interim discussion. So that's put into the public.
Super. Thanks. Thank you, Mike, and thank you, members. And I'd like to thank Kath once again for welcoming her to one of the best scrutiny meetings in Calderdale. We hope you've enjoyed the experience. It's been good to have you on. It's good to have you on board. I say a very big welcome to you here in Calderdale.
Thanks ever so much, and it's been really interesting and lively kind of meeting. So yeah, I've really enjoyed it, and thank you.
Absolute pleasure. Right, members, I now formally close the meeting. So thank you for your contribution.